Hello, everyone. Thank you for joining today's Web Interface support call for Shared Saving Programs ACOs. This presentation will be followed by a Q&A session where attendees will have an opportunity to ask questions via phone and support call questions box, and CMS subject matter experts will address as many questions as time allows. Also to note, a recording of the slide deck from today's call will be posted on the QPP webinar library within the next 2 weeks. I will now turn it over to Lisa Marie Gomez at CMS to begin. Lisa Marie.
Thanks, Haley. Welcome, everyone, and thank you for joining us today as Shared Savings Program ACOs prepare for quality reporting. Again, I'm Lisa Marie Gomez of CMS. Joining me on the call today are other experts who will share helpful information on the CMS Web Interface quality reporting and answer your questions following today's presentation. Today's call will only focus on 2023 CMS Web Interface quality reporting. You can contact the Quality Payment Program Service Center with any questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Today's slide deck, as previously noted, the slide deck, the recording, the transcript will be available in the Quality Payment Program webinar library within the next 2 weeks. Next slide, please. This is a disclaimer slide regarding this presentation. So the information in this presentation is current at the time it is published, but we encourage you to please be sure that you're using the source documents and links that are provided throughout the presentation. Next slide, please. Now I'm going to discuss announcements and reminders. Next slide, please. The CMS Web Interface will close at 8 p.m. Eastern Time on April 1st, 2024. Your submission will automatically be accepted at submission close. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website. Next slide, please. Dates for all upcoming bi-weekly support calls are listed on this slide. But as a reminder, the next support call is on February 7th, 2024. More information and registration links can be found in the 2023 CMS Web Interface support flyer. Next slide, please. As a reminder, the CMS Web Interface API is available all year for testing in the development preview environment. Please review the links listed here for more information. Now I will turn the presentation to Kara Sokol, who will discuss the 2023 CMS Web Interface measures and benchmarks. Kara?
Thank you, Lisa Marie. Next slide, please. This is Kara with RTI International, and I will be addressing which of the CMS Web Interface measures have benchmarks for 2023. Next slide. For reference, this is the full list of CMS Web Interface measures, including both the Web Interface measure identifier and the corresponding MIPS quality ID. Next slide. For 2023, there are 2 Web Interface measures that do not have benchmarks and therefore are not eligible for scoring for 2023. Those 2 measures include statin therapy for the prevention and treatment of cardiovascular disease and depression remission at 12 months. Both measures do not have benchmarks and therefore won't be scored for 2023. However, they are required to be reported to complete the Web Interface dataset. The remaining 8 Web Interface measures do have benchmarks for 2023 and are eligible for scoring for Web Interface. The table included here displays the benchmarks for each of the 8 measures, and the 2 non-benchmark measures are displayed as not applicable. For more information on benchmarking, you may reference the Web Interface benchmarking document available via the QPP resource library. And for more information on scoring of CMS Web Interface measures, you may reference the scoring guide that's included in the APP toolkit, also available in the QPP resource library. Next slide. We also wanted to provide today a reminder of the applicability of the Shared Savings Program EUC policy for 2023. The public health emergency for the coronavirus disease was in effect starting January 2020 and expired May 11th, 2023. All Shared Savings Program ACOs were deemed affected by the PHE for COVID-19. Therefore, for performance year 2023, an ACO's minimum quality performance score will be set to the equivalent of the 30th percentile MIPS quality performance category score across all category scores, excluding those entities or providers eligible for facility-based scoring. Therefore, if an ACO reports quality data via the APP and meets MIPS data completeness and case minimum requirements, then CMS will use the higher of the ACO's health equity adjusted quality performance score, or the equivalent of the 30th percentile MIPS quality performance category score. As such, all ACOs that qualify for shared savings for 2023 will be eligible to receive the maximum shared rate for their track, and any shared losses determined to be owed to CMS will be reduced by at least 5/12. And now I'll turn it over to the next speaker. Next slide.
Hi, good morning, good afternoon. This is Carrie Barrows. I'm a member of the Web Interface product team, and today I'm going to share with you a little bit about the edit demographic data capability for the web interface. Next slide, please. You are able to edit patient demographics via the Excel upload. Only the following items can be updated via the Excel upload: medical record number, clinic ID, and general comment. There are additional fields that can be edited and only be edited through the CMS Web Interface application proper. We do this to prevent accidental editing of demographic information in bulk that would prevent you from locating the patient later to fix the issue. Next slide, please. An example of when you might want to make an edit to the patient demographics in the CMS Web Interface is when you have found a mismatch between the date of birth in an EHR system and in the web interface system. You are able to make a change to the web interface system to update that date of birth to match what you have in your EHR. To do that, you would go to the Edit Info button, which is on the far right of the header with the patient name in it when you're in report data and in other places in the application. You would click on Edit Info, and that will open a small form that you are allowed to make the changes to for first name, last name, date of birth, and gender. And in this scenario, you would be updating the date of birth. You would make the change. You will be shown a warning that making a change to the date of birth may change the eligibility of that beneficiary or patient when it comes to how they are reported for the sample. But you are able to go ahead and save that. And in most cases, if you're just making a change to align with your EHR, there won't be any impact to whether that person is skipped or not in the sample. This presentation that you're seeing here, what's blurred out, in case you're wondering, is patient name. Even though it wasn't a true patient name because we aren't using any real data, it's only fictional data for informational purposes. We did make a choice to blur out any name information for this presentation. If you want more information on how to edit a patient demographic information for a beneficiary or a patient, You can review pages 21 through 23 of the 2023 CMS Web Interface User Guide, which is available on the QPP Resource Library. Next slide. And now I will turn it over, and my apologies, I'm not sure who I'm turning over to, for someone to speak about Prev 7.
Thank you, Carrie. This is Deborah from the PIMS team, and I will be covering the Prev 7 slide, which is the preventive care and screening influenza immunization review. And hopefully this does clarify some of the questions that we've been receiving. Next slide, please. So for the 2023 CMS Web Interface patient sample Excel files, in December of 2023, CMS delivered a CMS Web Interface patient sample Excel file to each of the ACOs reporting quality for performance year 2023. The file contains the same patient sample that's available through the CMS Web Interface at the start of the CMS Web Interface reporting period, which began on January 2nd, 2024. The patient sample uses Medicare administrative data from January 1, 2023 through October 31st, 2023. New for the performance year 2023, two variables are used to identify which flu season or seasons that patients had an eligible encounter for the 2023 CMS Web Interface Prev 7 measure from January 1st, 2023 through October 31st, 2023. As you can see, Prev 7 _ 2022 _ 2023 flu corresponds to the flu encounter timeframe, January 1, 23 to March 31, 23, that overlaps with the 2022-2023 flu season. Performance is assessed on influenza immunizations administered from August 1st, 2022 through March 31st, 2023. For the Prev 7 _ 23 _ 24 flu, this corresponds to the flu encounter timeframe of October 1, 2023 to October 31, 2023, and overlaps with the 2023-2024 flu season. In this case, performance is assessed on influenza immunizations administered from August 1st, 2023 through December 31st, 2023. All patients, regardless of whether they're ranked for the 2023 CMS Web Interface Prev 7 measure as provided within your ACO's patient sample file, have both variables coded as 1 equaling patient does have a qualifying encounter, or 0 equal patient does not have a qualifying encounter. However, for purposes of reporting the 2023 CMS Web Interface Prev 7 measure via the CMS Web Interface, ACOs should concentrate on their ranked patients for Prev 7. Next slide, please. And as folks have noted, for the flu season, when you have no encounter pre-populated, ACOs are only expected to report on the flu season or seasons for which the patient is sampled. If a patient wasn't sampled for a flu season, this is reflected as no encounter within the CMS Web Interface. ACOs can't enter data for the visit or the quality action, even if your organization identifies other visits for the patient and the quality action was completed. The CMS Web Interface doesn't allow data to be entered for a patient who isn't included in the sample for a measure. And this is the same whether it is for Prev 7 or any of the other measures within the web interface. If a patient isn't sampled for a measure, there is no way for you to add that patient. No encounter can't be changed within the CMS Web Interface. Next slide, please. The 2023 CMS Web Interface Prev 7 measure is the only measure where numerator-specific data is pre-populated. And this is similar to previous years. So if you've done web interface for a while, there should be no difference in this regard. Influenza immunization is pre-populated with a yes or a no for all patients ranked in the 2023 CMS Web Interface PREV7 measure. Yes is only pre-populated for patients in which an immunization could be identified in the claims data by CMS. If influenza immunization is pre-populated with yes, showing the patient had the immunization, no additional validation is needed. The Shared Savings Program ACO won't have to provide medical record documentation for pre-populated influenza immunization data. If influenza immunization is pre-populated with no, the Shared Savings Program ACO should refer to the patient's medical record to determine if an influenza immunization was administered in accordance with the 2023 CMS Web Interface PREV7 measure specification and must document their findings in the CMS Web Interface. The influenza immunization data that's obtained from the medical record is subject to the provisions of supporting documentation. So in this regard, if you have pre-populated no, and you find the patient has documentation of immunization during the appropriate time frame, you should change that to yes. If you find a denominator exception, you should change it to the appropriate denominator exception. This is different than the no encounter that we just went over, where you cannot change no encounter because that patient has not been sampled for that flu season. Next slide, please. And the next couple of slides are just examples of what you may see. So this example is for the 2022-2023 flu season that includes a no encounter for the flu season 2022-2023. As previously stated, you cannot change no encounter. However, the patient was populated for the 2023-2024 flu season and was pre-filled as a yes. The flu vaccine was provided and identified through claims. Nothing else is needed for this particular patient. The patient has met performance. Next slide, please. So this example, we have a no denominator exception for a medical reason identified for 2022-2023. This would have been changed from a no to no denominator exception based on your medical record documentation. For the 2023-2024 season, this is identified as a no encounter. The patient wasn't sampled into that flu season. That should not be changed. In this particular example, this patient would be a denominator exception. So the patient has been completed. Next slide, please. So this is the visual representation that we shared a couple of weeks ago. You will see that we have also added some not sampled no encounter information in the hopes to add some additional clarity. So when a patient is sampled into both flu seasons, performance will be evaluated based on the administration of the immunization during both flu seasons. The table below represents the performance outcomes when a patient is sampled into both flu seasons. For your reference, the 2022-2023 flu season corresponds with qualifying encounters from January 1, 2023 to March 31st, 2023. And performance is assessed on influenza immunizations administered from August 1, 2022 through March 31st, 2023. For the 2023-2024 flu season, this corresponds with qualifying encounters from October 1st, 2023 to October 31st, 2023, and performance assessed on influenza immunizations administered from August 1st, 2023 through December 31st, 2023. So if you look at the 2023-2024 flu season, and you note that you have an immunization administered during that flu season, as well as the 2022-2023 flu season, this would meet performance. Anytime the immunization is administered, or you have, during another flu season, you have documentation of a denominator exception, these would all be meeting performance. So both flu seasons, you've gotten the flu vaccine, this meets performance. One flu season, the influenza immunization was administered, and the other flu season is a denominator exception. This meets performance. If you have an immunization administered in one flu season and a no encounter during a second flu season, this also meets performance. It is not applicable. You will not see instances where you have a no encounter during both flu seasons, as that patient was not included in the sample for the PREV7 measure at all. However, if you have a not sampled for one flu season and documentation of administration of the influenza immunization during another flu season, you will meet performance. Performance is not met in situations where a patient is sampled in both flu seasons, and in one flu season, the immunization was not administered, and there is no denominator exception identified. If you have a patient that is included for just one flu season, you're just going to address that single flu season, as you cannot change the no encounter. Next slide, please. And I will hand it off to my colleague, Katie Moore, at this time. Thank you.
Thanks, Deb. Now we're going to review some frequently asked measure questions. Next slide, please. The first measure we're going to cover today is PREV10, Preventive Care and Screening, Tobacco Use, Screening and Cessation. The intent of this measure is to screen patients 18 years and older for tobacco use one or more times within the measurement period, and to provide tobacco cessation intervention during the measurement period or the 6 months prior to the measurement period if identified as a tobacco user. In regard to PREV10 and use of telehealth, the screening for tobacco use may be completed during a telehealth encounter, and tobacco cessation intervention may be completed during a telehealth encounter. Next slide, please. Okay, now we'll address some frequently asked questions related to PREV10. For 2023 PREV10, what's needed to satisfy the screening portion of the measure? So the intent of the measure is to determine if the patient was screened for tobacco use at least once during the 2023 measurement period. Therefore, if a clinician has documented a status for any type of tobacco use, that could be non-smoker, smokes, or uses smokeless tobacco, that meets the performance requirement for the screening component of the numerator. Question 2, does the measure include electronic cigarettes or vaping as tobacco use? Yes, the definition of tobacco use was updated for the 2023 measurement period. Use of any tobacco product includes any product made, derived from tobacco intended for human consumption, except products that meet the definition of drugs. Administration definition of tobacco, which includes e-cigarettes, hookah, pens, and other electronic nicotine delivery systems. The intent of the screening portion of the measure has been met if the most recent tobacco use screening has documented status of tobacco user or tobacco non-user. Question 3, there are 3 rate and population categories. Which rate or criteria is used for performance scoring for the 2023 performance period? The rate for population 2, tobacco users receive tobacco cessation intervention, is used for consideration of performance for this measure. Question 4, who is able to complete the cessation intervention within our organization? Can it be a medical assistant, or does it need to be an eligible clinician? Cessation counseling can be provided by anyone your organization considers qualified. Next slide, please. Question 5, what if the patient had more than one tobacco screening during the measurement period? Which one do we use? The response is, if there's more than one in patient query regarding tobacco use, you would use the most recent query during the measurement period to determine tobacco status. Question 6, when does tobacco cessation intervention need to be completed for patients identified as tobacco users? Patients identified as a tobacco user must receive tobacco cessation intervention during the measurement period or in the 6 months prior to the measurement period. The screening for tobacco use and cessation intervention don't have to occur at the same encounter. Question 6. Does the screening that was done in the emergency department or inpatient count? Yes, the setting isn't specified for this measure. Question 8. If there's a medical reason for not screening or providing tobacco cessation intervention to the patient, can we report an exception or exclude them? The answer is no. The measure doesn't allow for any denominator exceptions or exclusions. The expectation is that all patients qualified for the measure are screened for tobacco use and receive tobacco use cessation if identified as a tobacco user. Next slide, please. Okay, now we will cover HTN2 controlling high blood pressure. The intent of this measure is for patients 18 to 85 years of age who had a diagnosis of essential hypertension starting before and continuing into or starting during the first 6 months of the measurement period, and whose most recent blood pressure was adequately controlled during the measurement period. For HTN2 and use of telehealth, a blood pressure reading may be taken either by a clinician or a remote monitoring device and conveyed by the patient to their clinician during a telehealth encounter. Don't include blood pressure readings taken by the patient using non-digital device, such as with a manual blood pressure cuff and stethoscope. Next slide, please. Okay, now we'll address some frequently asked questions for HTN2. For the 2023 HTN2 measure, what is the definition of a remote monitoring device? The 2023 CMS Web Interface HTN2 measure specification doesn't define a remote monitoring device. It's the clinician's responsibility and their discretion to confirm the remote monitoring device used to obtain the blood pressure is considered acceptable and reliable. Question 2, for the 2023 HTN2 measure specification, is a blood pressure reading taken during an urgent care visit acceptable? Yes, blood pressure readings from urgent care visits are acceptable for this measure if it's the most recent blood pressure documented in the medical record. Urgent care visits are included in the sample based on Encounter Codes tab of the 2023 CMS Web Interface HTN2 coding document. Question 3, can we use a calculated average of multiple blood pressure values taken over the course of a week via remote monitoring device? The answer is no. It isn't acceptable to submit a blood pressure average, an average of 2 or more blood pressure readings. The measure requires the most recent blood pressure documented within the medical record during the measurement period to be reported for the numerator. If there are multiple blood pressure readings on the same day, use the lowest systolic and the lowest diastolic reading as the most recent blood pressure reading. Ranges and thresholds don't meet the criteria for this measure. A distinct numeric result for both the systolic and diastolic blood pressure reading is required for numerator compliance. Next slide, please. Okay, that brings us to the end of our frequently asked measure questions. Now I will hand things back to Lisa Marie to cover resources and where to go for help.
Thank you, Katie. So the next few slides will outline the available CMS interface resources. Next slide, please. Please note that the 2023 submission resources are available on the Quality Payment Program Resource Library. We encourage you to review these documents if you have questions on quality requirements and measures. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. Now I will turn this portion of the presentation to Haley, who will begin the Q&A session.
Thank you, Lisa Marie. We can go to the next slide. Thank you. We're now going to start the Q&A portion of the webinar. You can ask a question via the Q&A box or through the webinar audio. To ask a question via the webinar audio, please raise your hand and we will unmute your line so you can speak. To submit a question anonymously via the Q&A box, please click Send Anonymously. Otherwise, all attendees will be able to view your question. So to start off, we have a question in the Q&A box for Deb, and the question reads, for the 2023-2024 flu season, if patients are pre-populated with no encounter, but have the documentation that they did have a qualifying encounter between October 1st and December 31st, 2023, and received their vaccine between August 1st and December 31st, 2023, can we change that no encounter to yes, flu season 2023-2024? To my understanding, if the patient was seen in the fourth quarter, the information pre-populated into the tool would not be correct. If we cannot change the information, then what are we verifying and how will we pass this measure?
Thank you. All right, this is Deb. I'm going to try and go through this again, but there are several Prev 7 questions within the queue, so I'm sure we'll have some additional opportunities. As I previously stated, no encounter cannot be changed. And what it might help to kind of think of it as, let's put this into the perspective of a different measure. If you're reporting Prev 5, the breast cancer screening measure, and you happen to be going through your records and you happen to see Deborah Joe had a qualifying encounter and she has a mammogram during the appropriate time frame, but she is not included in your patient sample. You can't just add her to your patient sample and then move forward with reporting both the denominator and numerator outcome. And that is what this no encounter in Prev 7 is trying to articulate to you. That when the sampling was pulled together, because we are now looking at 2 different flu seasons, there is the possibility that a patient is included in your sample for one flu season and is not included in your sample for another flu season. And it could be either one of the flu seasons. So no encounter cannot be changed. And this is not going to hurt you. You would just be submitting information based on a single flu season and the outcome. So another example here is, let's say you have no encounter on one flu season, and during the other encounter, it's pre-populated as a no. And as you've gone through your medical record documentation, you see that that patient did not receive a flu vaccine. Even if you were able to change a no encounter and you could identify it as a yes, they received the flu vaccine in the second flu season, the fact that the patient was a no in the other flu season would result in a performance not met. So keeping it as no encounter doesn't change the outcome of the performance not met in that scenario. It will also not change the outcome if in one flu season you had a documentation of a denominator exception, and in the other flu season, it's a no encounter. That is just a denominator exception. So again, you're not able to change the no encounter, and I would just recommend looking at it as any other measure within the web interface. You can't add to your sample. You have to submit based on what's there. Hopefully that answered this first question, and I'll try to answer some more. And I know my colleague Carol will also be answering some of these Prev 7 questions, and I'll let you move on to the next one, and we'll get back to some more Prev 7 later.
Thanks, Deb. Next, we're going to take a question from the phone line. So, Susan, we have unmuted your line if you would like to unmute yourself to ask your question.
Hi, this is Susan Rameli. Can you hear me?
Yes, we can.
Okay. Yeah, my question is related to diabetes 2. We have actually 2 patients in our sample who where we're trying to confirm the diagnosis. And for the PCP, they're very clearly on both of those patients, he's documented that they're pre-diabetic, that they do not have diabetes. However, both of these patients have also seen a specialist during the measurement year where the specialist used a diagnosis code for diabetes. So both are kind of in the documentation. Both cases, they would pass the measure because they're not diabetic, so their A1C is controlled, but we don't think that they would be appropriate. But we're just wondering do we stick with what we found with the PCP, or because the specialist used a diagnosis code for diabetes, do we have to, would they be qualified for the sample?
Hi, this is Angie from PIMS. I think I just answered your ticket this morning.
Yep.
But you gave a little more information this time. Although we can only answer with the specifications, so the measure doesn't limit it to a certain provider type. So if there's medical record documentation along with that code to support that the patient does actually have diabetes, and it is one of the diagnosis codes listed in the for eligible encounter, or eligible patients in the coding document, then the patient would be included. If there is a discrepancy, I guess I would suggest going back to the physicians. But if the specialist diagnosed them with diabetes that falls under the measure, then it would normally be included. That's about all we can tell you from the perspective of the measure specifications.
Okay. Yeah, I guess I'm still not sure which one we should, like both cases, we do not think the patient's diabetic, even though the specialist did use a code that is within the coding reference. So we didn't know if the PCP who's actually would be managing the diabetes, if they, they're managing their pre-diabetes, so it feels like that should trump that they should not be included. Like I said, they would both pass the measure, so it's not like, but we don't feel that they're appropriately diagnosed as diabetics by those specialists.
Yeah, we can't really address if you feel the medical record documentation is incorrect that the specialist included. Hopefully there's some supporting documentation around that diagnosis other than just a code, but that's there is documentation in their note. Like one of them was diabetic retinopathy is what they use for the ophthalmologist, but yes. Yeah, I don't know if that is, you have to look at the diagnosis codes, but if it is one of the ones included on the Prep 6 coding document, then you would include that patient as diabetic.
All right. Thank you, Susan. In the interest of time, we're going to move on to our next question. So our next question in the chat is for Katie, and the asker wants to know, how do we submit a custom exception?
Hi, thank you. So I'm going to go ahead and assume that a custom exception would be the other CMS approved reason to skip a patient. If that's the case, I can talk you through that process. And then I would also refer you to the CMS Web Interface user guide. The steps are outlined starting on page 45. But within the tool, in the section where it asks, is the patient qualified for this measure, you'll have an option to select no and then request an other CMS approved reason. When you click that, it will have you populate your email address and some additional information as to why the patient isn't qualified for the measure. Here we would just ask that you provide as much detail as possible as to why the patient should not be included in the measure. We also ask that you ensure you're reviewing the measure specification to make sure there's no applicable denominator exclusions or exceptions. In those instances, you would go ahead and continue reporting based on those outcomes rather than submitting a skip request. And then we'll go ahead and process those. If we have additional questions for you, they would come from the CMS Web Interface support mailbox, and then you'll receive a decision within the tool that shows if it was approved or denied. Thank you.
Thanks, Katie. And then we have a question from Kim on the phone. Kim, we have unmuted your line if you would like to unmute yourself. Okay, Kim, we can come back to you.
I'm sorry, this is Angie from PIMS. Can I just jump back for 1 second? I
Sure.
know when I was answering the live questions about the diabetes measure, I kept saying, I think I said the Prep 6 coding document, and it's because I was looking at something else. But obviously I did mean the DM2 coding document. And also, if you can't verify the diagnosis, then it'd be appropriate to say diagnosis not confirmed, if that's what you come up with after reviewing the medical record documentation. Thank you.
Thank you. Okay, so next in the chat, we have another question for Katie for Prev 12. Is PHQ-9 or PHQ-2 of 0 assumed negative?
Hi, thank you for the question. So when it comes to documentation for Prep 12 for 2023, the specification notes that documentation that a screening was conducted with a standardized depression screening tool is recommended that you include both a score and clinician interpretation of the score, especially when a patient screens positive. At a minimum, the medical record must contain documentation of the tool's name and results of the screening with a score or clinician interpretation of positive or negative for depression. So the intent of this language is to allow flexibility in how organizations are documenting the outcomes of the depression screening. The specifications state a clinician should review the results, but how the results are documented is up to the organization, as the measure spec allows some flexibility there. In all cases, your medical record documentation should support the information reported, and therefore, if you're meeting the minimum requirement, again, that's documentation of the tool's name and the results of a screening with a score or interpretation, then you're meeting the intent of the measure. Thank you.
Thanks, Katie. And we actually have another question about Prev 12 for you. And that question is for Prev 12, can the major depression exclusion be from 2023, or does it need to be before the measurement period of 2023?
So for Prev 12, just to clarify here, the denominator exclusion would be a diagnosis of depression or bipolar disorder. The timing of that exclusion would be prior to any encounter during the measurement period. And then if you take a look at the measure specification on page 9, there's a little bit of additional language here to provide some guidance. And so that language states, to implement this guidance, the qualifying encounter is equivalent to the most recent depression screening. A patient should be excluded if they have ever been diagnosed with depression or bipolar disorder prior to the qualifying encounter used to evaluate the numerator. Thank you.
Thanks, Katie. And then we have a question on the line from Carolyn. Carolyn, we have unmuted your mic if you would like to unmute yourself.
Hi, yes, I have a general question, sort of related to our EMR, but I'm guessing it may apply to others. So for our EMR, we have access to outside providers that, upload information into our EMR. So if we have access to those external records for services provided in 2023, however, those records were only downloaded into our EMR when we started to look for them as part of this process, can we use those records for reporting?
This is Deb. Just to kind of clarify your question, are you asking if you can use documentation that you downloaded and are reviewing in 2024, but that you didn't have access to in 2023 for reporting the information for a 2023 measure?
Sort of. We already had access to it. So we have, like through Care Everywhere, it populates into our EMR, but we have to then click the link to open it up and review it. And that is when the summary is generated. But the visit is actually from 2023.
Hi, this is Katie from the PIMS team. So, if you're able to obtain medical record assigned to your sample beneficiaries, including collaborating with other physicians or clinic staff, both inside and outside your ACO, as well as other facilities, and you have those collaborative attempts being repeated through the course of the data collection period, that information can be used. Just note that information entered into the CMS web interface should never reflect services provided after the end of the performance year. So as long as it reflects what was completed before December or on or before December 31st, 2023, then that information can be used.
Okay. Thank you for clarifying that.
All right, thank you. The next question in the chat is for Sandra. And Sandra, the question reads, how does the flu have a benchmark given the changes to the measure?
Thank you, Haley. This is Sandra from the Division of Quality and Price Transparency. And there are a few questions about benchmarks for PREV7, so this response should address those questions. So in calendar year 2023, Medicare Physician Fee Schedule Final Rule, we finalized the proposal to designate a performance benchmark and a minimum attainment level for each CMS web interface measure, and to establish a point scale for the measures for performance years 2022, 2023, and 2024. We finalized the proposal to set benchmarks using flat percentages for 8 of the CMS web interface measures that are scored. And as noted by Kara earlier, 2 web interface measures do not have a benchmark and are not scored. We did have discussion that the use of flat percentages allows ACOs with high scores to earn maximum or near maximum achievement points, and also allows room for improvement and rewarding the improvement in subsequent years. Thank you.
Thank you. The next question we have is for Carol about PREV7. What is an eligible encounter for PREV7?
Hello, this is Carol with the PIMS team. So an eligible encounter is equivalent to the encounter codes tab. If you look in within that, so PREV7 within the coding document on the QPP resource library identifies coding that may be used, the denominator coding that may be used to identify the eligible encounter. Thank you.
Carol, I think you cut out.
I'm sorry, I was coughing. So within the denominators codes tab, there's a list of coding that can be used for confirming whether or not the patient is denominator eligible for the measure. Thank you.
Thanks. The next question is for Katie, also about PREV12, specifically the data extract Excel template. The web interface Excel template includes the following language: Is follow-up plan documented on the same day as positive screen? However, the specification workflow notes patient had a follow-up plan for depression documented on the date or up to 2 days after the date of the qualifying encounter. Can you please clarify this time frame for follow-up plan documentation?
I thank you for the question. So for Prep 12, the guidance and the measure specification should be used as a source of truth. So the positive screening should be documented on the date of the encounter used to evaluate the numerator, which would be associated with the most recent screening. And then you have the time frame, the additional 2 days after. So just to reiterate here, the encounter would be the date of the positive screening or the date where the numerator action was completed. So you have 14 days prior to the date of the encounter using the screen, and then up to 2 days after the date of the qualified encounter. Thank you.
Thank you. The next question we have is for Deb. Specification for Prev 7 states, flu season 2023-2024, the patient must have a qualifying encounter between October 1st and December 31st. Can you please confirm this is what you noted?
Yes, and thank you so much for this question. And while I answer this, I'm going to ask if it's possible to show slide 15, as I know that was a request further down in our question and answer. And hopefully this helps kind of clarify. So you are absolutely right. We did state that the October 1st through October 31st, 2023 for that second flu season. And I may need others on the call to kind of confirm my verbiage here, but that is specifically related to when the sample ends. So the flu season itself that's being measured is going through December 31st of 2023. So you can look for, if you have a patient that was sampled into the 2023-2024 flu season, you can look through December 31st of 2023 for the vaccine. You can also look up to August 1st of 2023 for previous receipt. So that October 1 to October 31, 2023 is specifically related to sampling, not to the flu season itself. So hopefully that clarifies both this question. I'm not sure exactly what the individual was looking for that wanted to look at slide 15, but I do know that there were several questions in relation to the October 1 to October 31 dates. So hopefully that clarifies. If not, I will look towards the end of the question and answer and see if there are follow-ups. If we don't get to those follow-ups today, I would recommend opening up a ServiceNow help desk, and we will be able to go ahead and address your questions in that manner as well. Thank you.
Thank you. And we have pulled slide 15 back up for folks to see again. Deb, we did have another question for you, and that is if we change the selection to yes for Prep 7, do we also need to include the supporting documentation or only if requested?
So the supporting documentation, I'm assuming that is referring to if there was an audit, and so that would be just upon request. So if you have a yes pre-filled for Prep 7, what CMS has said is you won't be asked for anything because they found the immunization through claims data. If you change from a no to a yes, the expectation is that you have medical record documentation to support that selection if you were asked for it. Thank you.
Thanks, Deb. We do have another question for you. If patient has an exception, why is it listed as performance not met?
Okay, and that one would be on slide 20. So if you have a denominator exception during one flu season and you have an immunization not administered during another flu season, that would be a performance not met. But if you have documentation of a denominator exception during one flu season and the flu vaccine administered during another flu season, that would meet performance. If you have documentation in both flu seasons of a denominator exception, that would be considered a denominator exception. I think that should clarify, but again, if you have some follow-up, please let me know.
Thank you. The next question we have is for Carol, and the question reads, does hypertension with I-10 code meet the HTN2 criteria?
Hi, this is Carol again. That would be no. If they do not have essential hypertension, the measure requires confirmation of essential hypertension, and it is also referred to as primary hypertension, and the denominator codes can be used to identify what is considered acceptable for the measure for the diagnosis of essential hypertension. And you can use a combination of written documentation. An applicable code is acceptable for the numerator confirmation, and coding alone is not sufficient documentation for this medical record support. If you can confirm essential hypertension, then you would, if you cannot confirm essential hypertension, then you could not confirm the diagnosis. Thanks.
Thank you. The next question we have is for Prince. Prince, the question states, if a provider terms from the ACO and we are unable to collect the data from that office, can we use the medical record not found option?
Hi, this is Prince Bonsu from ACO PAOS. So the no medical record found option should be used only if there's a truly an inability to locate and access the patient's medical record. By virtue of being sampled into the CMS Web Interface, CMS has identified claims for the patients submitted by the ACO. So CMS does expect organizations to be able to obtain medical records for their assigned and sampled patients. This includes collaborating with physicians and/or other clinic staff both inside and outside the organization, including but not limited to the 3 MPIs provided in the CMS Web Interface, as well as facilities both inside and outside the organization, with such collaboration attempts being repeated throughout the course of the data collection period if needed. If after such efforts, the ACO is unable to locate the medical records for the sampled patients, it would then be appropriate to use the no medical record not found option. Thank you.
Thank you. And we have another question for Deb. And that question reads, can the encounter be with any clinician specialty within the ACO for flu?
Yes, this particular measure does not specify who that encounter needs to be with. Thank you.
Thanks, Deb. Our next question is for Angela. Angela, the question reads, Prev 6, a qualifying code for colonoscopy is found, but the results of screening is incomplete. This would not qualify to be used for the screening, correct?
Hi, yes, that is correct. The numerator requires that you determine if the colorectal cancer screening for the patient is current during the measurement period. So incomplete results for inadequate prep would not meet the intent of the measure and wouldn't substantiate that the patient was current on their screening. There is numerator guidance that says there must be both the date the screening was performed and the result or findings, and that normal or abnormal are acceptable. Thank you.
Thanks. The next question we have is for Carol. That question reads, is documentation for a colorectal cancer screening of last colonoscopy Y10/2016 and is listed under past medical history, and last colonoscopy 2016 no polyps is listed under the assessment plan on the same office visit note. Is this acceptable documentation for CRCS?
I can't really speak to your documentation. However, if you can confirm that the patient has had a colonoscopy within the last 9 years or during the measurement period, then that would suffice for meeting the denominator for the measure.
Thanks, Carol.
The
We
numerator,
have,
sorry.
sorry, we have another question for you. For CARE 2, is there any documentation guidance or requirements of gait or balance assessment meets the intent of the measure?
Okay, so for CARE 2, medical record documentation of screening for falls risk or gait assessment would meet the intent of the measure and address that the patient has been screened. The use of assessment is not specific to the use of screening tool, but it may also include an assessment performed with or without a screening tool by the clinician. Any history of false screening during the measurement period is acceptable as meeting the intent of the measure.
Thank you. The next question we have is for Deb, and the question reads, is documentation of a cessation intervention excuse me, I'm going to start over. Is documentation of a cessation intervention given considered sufficient for meeting the criteria of Prev 10?
I am so sorry for that delay. I thought I would be able to get to that specification since you started over, and that did not work for me. So I'm just going to go ahead and quickly read from the definition that has been provided in the Prev 10 specification for tobacco cessation intervention. And as previously stated, I think by Carol most recently, we can't speak to your specific documentation. In general, we just let you know that your documentation should support whatever it is that you are reporting. But there is on, say it is page 6 of the posted Prev 10 specification, a definition of tobacco cessation intervention, and that includes brief counseling, 3 minutes or less, and or pharmacotherapy. There is an additional note that concepts align with brief counseling, including minimal and intensive advice or counseling interventions conducted both in person and over the phone. And they are included in the 2023 CMS Web Interface Prev 10 coding document for the numerator. Other concepts such as written self-help materials and complementary or alternative therapies are not included in the 2023 CMS Web Interface Prev 10 coding document and do not qualify for the numerator. Counseling also may be of longer duration or be performed more frequently as evidence shows that higher intensity interventions are associated with higher tobacco cessation rates. Thank you.
Thank you. We have another question for Prince asking to please clarify the 2023-2024 flu season qualifying encounter date range. Prince, would you like to speak to that?
Yes, thank you. And I know Deb touched on it a little bit earlier, but just to clarify, so CMS uses Medicare administrative data, i.e. claims data, from January 1st, 2023 through October 31st, 2023 for sampling purposes, which is consistent with the January 1st through October 31st sampling window in past years. Therefore, only qualifying encounters from October 1st, 2023 through October 31st, 2023 were identified through sampling for the second flu season for Prev 7. Thank you.
Thanks, Prince. The next question we have is for Angela. The question reads, if a patient has a colonoscopy, Prev 6, and they say poor prep, does the colonoscopy still count? Does the colonoscopy need results?
Hi, I thought there were two of these. I think that's the question I just answered. A similar question. And no, there must be results in order for it to count for the measure. Thank you.
Thank you, and apologies, that was a repeat, but appreciate you asking or answering again. The next question we have is for Deb, and the question reads, is it permissible to use the state vaccine registry as a means to satisfy the Prev 7 documentation and counter requirement?
Thank you for that question. Yes, anything that you can use that supports that the patient received the influenza immunization vaccine can be used. Basically, you just have to be able to have access to that information if it is requested to confirm your documentation is accurate. Thank you.
Thank you. And I see we have a question on the line from DeForest. We have unmuted your line if you would like to unmute yourself.
Very good. Can you hear me now? Thank
Yes.
you. Wonderful. If we looked at our clinics list that we use to assign the measures to specific TINs, we see several records and clinic IDs that are listed as unknown. If using a different data source, we can zero in on who probably put that together. Is it permissible to assign a clinic ID to that if it's somebody that's on the list? Does that make sense? Rather than have the record just be sitting in limbo with either skipped or not filling out the data, if we know where to send it, can we assign it to that logical clinic ID?
Hi, this is Prince again from ACOPAOS. So just to note that the clinic ID is pre-filled for informational purposes and may be marked as unknown when it comes to the web interface patient sample file. The ACO does not need to force a change to the web interface patient sample file if they are able to find the clinic ID for their patient.
So we can go into the web interface document and replace the unknown clinic ID with one that we feel sure is where the patient encounter happened. Is that fair to say?
Within the actual web interface, I believe that's possible. And I think there's information on the web interface user guide about how to input that information. But in regards to the actual, oh, sorry.
Go ahead, please.
But in regards to the actual web interface patient sample file, since I believe your question was about forcing a change for that, the ACO doesn't need to force a change for the patient sample file.
Okay. Fair enough. Thank you.
All right. Thank you.
Thank you. The next question we have is in the chat for Katie, and the question reads, for Prev 12, if a patient screens positive for depression and the provider recommends medication and the patient refuses medication, is this still considered a follow-up plan?
Hi, thank you for the question. So for Prev 12, the clinician would still need to document that follow-up plan. So in this instance, that they would need to document that, pharmacological intervention was recommended for a treatment of depression or whatever that outcome was. Patient adherence to the medication isn't measured, so that piece would not be required. But in order to satisfy the measure requirements, you would still need to have supporting documentation that that follow-up plan was documented. Thank you.
Thanks, Katie. Our next question in the chat is for Deb. And the question reads, if a patient has a denominator exception for 2022-2023 flu season and a yes for 2023-2024 flu season, will the patient be skipped or included in the numerator?
In this case, that would be a performance met, but let me read that back to you, Hallie, to make sure that I caught that right. We have one flu season where the vaccine was administered and the other flu season with documentation of a denominator exception. If those are the two scenarios, that would be considered a performance met.
Thank you, Deb. That is how the question reads.
All right, thank you.
And for our next question, we have Lynn on the line. Lynn, we have unmuted your mic if you would like to unmute yourself. Lynn, are you there? Oh, I see you have lowered your hand. Okay, for our next question in the chat is for Carol. Would an influenza vaccine declination need to be documented in both October to December 2023 and then the January to March 2024 if they have encounters in both timeframes during the current season?
That is correct. Under the guidance section on page 6 of the influenza immunization measure, at the very bottom of the guidance is a sentence that denotes denominator exceptions are determined at the time of the denominator eligible encounter during the current flu season. And those denominator exceptions include documentation of medical reasons for not receiving the influenza immunization, which are like patient allergy and other medical reasons, documentation of patient reasons for not receiving an influenza immunization, which is patient has declined or other patient reasons, and then documentation of system reasons for not receiving vaccine, and that would be the vaccine not being available or for other systematic reasons. I hope that answers your question, and thank you.
Thank you. Excuse me. The next question we have is for Katie, and the question asks, a patient for statin measures has diagnosis of PAD, peripheral arterial disease with ICD I7 3.9. Will this patient qualify for statin measure?
Hi, thank you. So our recommendation for this when you're searching for a diagnosis would be to point to the 2023 CMS Web Interface coding documents. And in this instance, we would guide you to the denominator codes tab. So this would include all applicable denominator codes that would pull the patient into the measure. So our suggestion would be to take a look there to see if any of the codes or descriptions align with the patient's diagnosis. And then if you still have additional questions about confirming them in the denominator, we would suggest submitting a ticket. Thank you.
Thanks, Katie. And then the next question is for Deb. Can you clarify if a provider documents gait normal or abnormal meets the measure for Care 2, and what are the documentation requirements?
Thank you. And this is going to actually hopefully cover a couple of questions that are in the queue currently. Unfortunately, I cannot, as normal, we can't speak to specific documentation within your medical record. But on page 5 of the posted Care 2 measure specification, there is a definition for screening for future fall risk, which includes assessment of whether an individual has experienced a fall or problems with gait or balance. A specific screening tool is not required for this measure. However, potential screening tools include the Morse Fall Scale and the Timed Get Up and Go test. Documentation of a fall would include a sudden unintentional change in position, causing an individual to land at a lower level on an object, the floor, or the ground, other than a consequence of sudden onset of paralysis. epileptic seizure, or overwhelming external force. So basically, our recommendation would be to take a look at those definitions and your medical record documentation. And if your documentation supports that information, it would be sufficient for the Care 2 measure. Thank you.
Thanks, Deb. And the next question is for Carol. And the question is asking for additional clarification on the question related to hypertension and I-10, and asking if you could please restate the answer to that question.
Hello, sorry to confuse you. This is Carol. So for this measure, the measure requires confirmation of essential hypertension diagnosis. We recommend you use the hypertension coding document to identify the denominator codes that are applicable to identifying the diagnosis regarding the appropriate hypertension diagnosis. You can use a combination of written documentation and an applicable code for meeting this requirement. The EHR mapping is considered to be all-inclusive. And I think that's it. As long as you can confirm the diagnosis from the most, then you can, confirm the patient for this measure.
Thanks, Carol. The next question we have in the chat is for Prince. And the question asks, a patient had different insurance 3 months in 2023, wanting confirmation that this would be a skip as non-fee-for-service Medicare, since the patient did not have fee-for-service Medicare for all of 2023.
Yes, so if the primary coverage for the patient was not Medicare fee-for-service for at least some portion of the measurement period, then it would be appropriate to exclude the patient. If the primary coverage for the patient was Medicare fee-for-service for the entire measurement period, then there would be no reason to exclude the patient from the sample. Thank you.
Thank you. The next question we have is for Deb, and the question asks, the ability to change no encounter to yes flu given is confusing, and wondering why Excel allows you to make a change that should not be made.
Thank you. And I will only be answering a portion of this question. If someone else on the call will be able to address the Excel document that this caller is referencing, that would be great. If we're not able to do that or we're not able to answer your question sufficiently, please open up a ServiceNow help desk question, and the teams will get together and be able to provide you with a response. But in regards to changing no encounter, as we have previously gone over within the web interface, you are not able to change no encounter, as that is just indicating that the patient was not identified during the time period as having an appropriate encounter. We understand that you may be finding some encounters after that sampling process. But as I've stated earlier, like other measures, we can't change the sample during reporting. So again, you can't change it within the web interface. I don't know if there's something different going on with the Excel. So if somebody else on the call can answer that, that would be great.
Thanks, Deb. Yes, this is Carrie. So the Excel file does allow you to make a change to the field, either by selecting something different in the dropdown or by overwriting the existing values using a copy and paste. That's due to the nature of Excel, and we aren't able to lock down just the fields that contain no encounter. So it's using the same list of values that would be used when a different value was in the field other than no encounter. We have the validation on the web interface side, which is why if you do make a change to it in Excel and do an upload, you'll see an Excel error in the web interface. That validation is there so that there is an indication to you that you tried to change it and that it's not allowed to be changed. And there's no further action that needs to be taken on those Excel errors. If you don't want the Excel errors, the only way to avoid that is to not change a no encounter value in the Excel using any mechanism that's available in the Excel tool.
Thanks, Carrie. The next question we have in the chat is for Katie, and the question reads, how can we formally report a member whose self-identified gender differs from the one currently listed in the CMS records?
Hi, thank you. So there's a couple things here. So in the instance that the patient's demographic information is incorrect, you can fix that within the CMS web interface. And just note that any demographic information you change in the web interface doesn't get reported back to the Medicare patient enrollment database. So if that's the case, then you would want to encourage your patient to contact Social Security Administration directly to have that information updated. In terms of a measure perhaps like PREV-5, breast cancer screening, if there are instances where the patient may not feel appropriate to have completed this measure on them, or there's questions of how things should be managed in regard to gender and PREV-5, you can request a skip if that seems necessary, or if there's additional detail that you want to provide and talk through with the PIMS team in regard to the measures, you can submit a ticket and then we can help you work through that. Thank you.
Thanks, Katie. And we have a question in the chat for Carrie. And the question is asking for clarification on the age issue for PREV-6. So Carrie, would you like to answer that?
Yeah, absolutely. So recently it was identified that the web interface application was using the age of 50 as the lower age limit for PREV-6. That has since been fixed, and a deploy was done midday on Monday. So if you're still encountering the age not confirmed in the Excel and you have done a download of the Excel after Monday, please submit a help desk ticket. If you are seeing it in an Excel file that was downloaded prior to Monday or before about midday Eastern time on Monday, you can either download a new file, which should have that fix in it, or you can work each one of those beneficiaries or patients in the web interface application to do the appropriate changes you need to make if you need to make any changes to them.
Thanks, Carrie. And we have a question on the line from Betty. So Betty, we've unmuted your mic if you would like to unmute yourself.
Yeah. Hi, guys. Just got a question here. I think it was Brian. I'm sorry, I'm not sure if I got your name right. But you had said a couple of minutes ago about if a patient had traditional Medicare partial time as primary insurance, then they would be okay. But so when you were saying that, were you saying that, like, let's say if they had primary insurance, traditional Medicare for until October, and then October they switch to an MA plan, doesn't that disqualify the patient?
Yeah, hi, this is Prince. So if the patient, no problem. If the patient has primary coverage that is not Medicare fee-for-service at any time during the measurement period, then it would be appropriate to skip that patient.
Perfect. Okay, I wanted to make sure because that's how we've been doing it. And then I had another question that was actually in the box. We came across a patient today that we were abstracting. So the patient had a referral done for palliative care while she was in the hospital. So she did have a visit by palliative care. They did goals and everything, but patient did not get followed by palliative care. So they basically said, yeah, it's no comfort care. So they just wanted to deny palliative care. Would that patient still qualify for the sample, even though that they were eligible for it and had the consult?
Hi, this is Katie from the PIMS team. So to use this for patient confirmation, the requirement only states that patient received palliative care goals. So given if your medical record documentation can support the received palliative care goals and that was discussed with the patient, you could select that they were not qualified for sample based on that medical record documentation supporting that.
Right, so just to confirm then, so if we have something like that, even though the patient declines palliative care, we can disqualify the patient for the sample.
So sorry, I may have misunderstood. I guess if they were receiving palliative care goals or comfort care and your documentation supported that, then you would be able to report that. In the instance that they declined that care, I think maybe that's something we would want to take a closer look at just to make sure that we're not steering you in the wrong direction. So if you want to go ahead and submit that question to the QPP Service Center, we can do a deeper dive into that. And then just note if you do go that route that we encourage you to put that it's for 2023 CMS Web Interface reporting within your email, just so to help expedite routing to our team.
Thanks, Katie. Seeing that we are at time, this will conclude the Q&A portion of the webinar. So I'm going to turn it back over to Lisa Marie Gomez to conclude the call. Lisa Marie.
Thanks. I want to thank you all for joining us today. As a reminder, the slide deck recording transcript from today's support call will be available on the QPP webinar library in the next 2 weeks. The next CMS Web Interface support call will occur on February 7, 2024, and we will cover frequently asked measure questions related to PREV 5 and PREV 6. Again, thank you for joining us, and we hope you have a great day. Thank you, everyone.